Hi, everyone. Sorry about that. A little bit of IT. There was going to be a little IT issues with Zoom. So welcome to this afternoon session on medullary thyroid cancer medical management at the beginning of the journey. If this is what you want to listen to, you're in the right place. I am Busaidy Grubbs. I am a professor of surgical oncology at MD Anderson Cancer Center in Houston, and I'm here with my fantastic colleague and very good friend, Dr. Busaidy, who's a professor in the Department of Endocrine Neoplasia and Hormonal Disorders. She is an endocrinologist. I am a surgeon. We work as a team together to take care of patients. And Naifa's going to get us started, and she's just going to tell me when to advance the slides.
Great. Thank you so much, Libby. So, this is how it always should be. Multidisciplinary care of all of you, or patients with medullary thyroid cancer. So we're going to try and make this informal. Unfortunately, you guys don't have access to ask questions by talking, but you can use the chat or the Q&A box, and we will address them as much as we can along the way, but definitely at the end, we have time for questions. Okay, Libby, next. So what we're going to talk about today is what can I expect after I am first diagnosed with medullary thyroid cancer. There are many talks about, systemic therapy or individual parts about surgery and long-term follow-up. So this is just sort of, I'm first diagnosed, what should I expect? Next. Okay, so in your first visit, your clinicians will be taking a comprehensive history and physical. And then once they know that you're diagnosed with medullary thyroid cancer, every patient should have what's called germline RET testing in the setting of a genetics counselor. So you'll meet with a genetics counselor, and that's a blood test. And we'll talk a little bit about that later. And then the cancer markers that will be drawn are serum calcitonin and CEA, and we'll talk about what those mean. And then you should get a really good neck ultrasound. So when we say comprehensive neck ultrasound, we're talking about the whole neck and not just the thyroid, okay? Unfortunately, many places, they just do what's called a thyroid ultrasound. You want to see all the lymph nodes of the neck, so a comprehensive neck ultrasound. Some places, they don't have good ultrasound, so they'll do a CT scan of the neck. Sorry about the background noise. Next. So, and the latest guidelines from the American Thyroid Association are from 2015 and are quite good and detailed in that regard. Next. So we always like to start with a patient scenario or a case, right? So there's a 65-year-old lady who comes in with a thyroid nodule found that she herself felt, and she admits to having some diarrhea. So otherwise she has no symptoms. And when we examine her, we see that she, on the left side of her neck, she has a thyroid nodule that we can feel. And so we schedule her for an ultrasound of her neck, and the biopsy shows that she has medullary thyroid cancer. So what do we do next, right? So we turn to the guidelines. Thankfully, there's several guidelines that are out there. There's the American Thyroid Association guidelines, which were published in 2015. And then there's the NCCN, or National Comprehensive Cancer Network, that has guidelines updated every year. And then there's the North American Neurondocrine Tumor Society, right? And most of them agree on most things. There may be some slight differences, but there's lots of places for your physicians or clinicians to look. So I'm going to focus on, or we're going to focus on, the revised American Thyroid Association guidelines from 2015, just for the interest of simplicity. So what does it say? So you have a biopsy of a thyroid nodule that shows that you have medullary thyroid cancer. You should meet with what's called a multidisciplinary team. That means it's not just one doc, right? So an endocrinologist who knows a medullary thyroid cancer, and a surgeon who knows medullary thyroid cancer. And that's key, is finding those docs who know about your disease. Then you'll have your blood measured for calcitonin levels and CEA, or carcinoembryonic antigen. And you should meet with a genetics counselor or if one's available. Otherwise, in some places, there's not a genetics counselor. You meet with a physician to talk to you about what does hereditary testing mean. So you get germline RET testing, or a blood test, to see if you have the hereditary kind of medullary thyroid cancer. Okay, so why do we even bring this up, right? Why see a genetics counselor? That's because there's two forms of medullary thyroid cancer. 80% of them are what's called sporadic, meaning they're not hereditary, they didn't come from mom and dad, and they don't go to children, right? But 20% of time when somebody's diagnosed with medullary thyroid cancer, this is a hereditary disease, right? So either it started with you and can be passed down to children in 50-50 manner, 50% of the time, or it came from parents, and you have a 1 in 2 chance of you having it. So that gene in the blood is called a RET proto-oncogene. And there's many, parts to that, but that will show up in the blood test. And if you have that, then that's called multiple endocrine neoplasia type 2, which is, we'll discuss later, is several disorders plus medullary thyroid cancer, or you could just have familial medullary thyroid cancer, meaning it runs in your family. So no matter how old you are, some people are like, oh, I'm already 60 years old. Do I really need this? Yeah, even if you don't, if you don't have children. So you have that discussion with your genetic counselor and your clinician, but every patient should be recommended to be tested for Rett germline mutation, because you don't know, you can't always tell who's in the 20% and who's in the 80%. So what does it mean to have hereditary medullary thyroid cancer, right? So there's two main types of medullary, hereditary syndromes associated with medullary thyroid cancer. There's MEN2A and MEN2B. And all of these patients will have medullary thyroid cancer, right? Because that's what you're coming here for the diagnosis for. But in MEN2A, 20% of the time you'll have large glands making extra parathyroid hormone, or what's called parathyroid hyperplasia. And about 50% of the time you can have a tumor of your adrenal gland that makes extra adrenaline called pheochromocytoma. In MEN2B, those are the patients you hear about that, yes, they have medullary thyroid cancer, but they can also have physical features that can help them identify that they have MEN2B. So mucosal neuromas, which are these features on the tongue you can see here on the right, bumps on the tongue, or you can have those in your gut. And about half the time you'll have those same tumors of your adrenal glands. So it's more than just the thyroid that's affected. This is a gene that's throughout your body that can cause different problems. So it's important that you see somebody who's an expertise in this so that they know what to look for, how to screen, and how to treat it. The mutation is found in every cell of your body, so you can measure it in your blood, and it is an activating mutation, right? So that means it can turn on other genes. So when we draw this blood, when you draw the blood for this genetic test called Rett, before you have surgery, there's still a couple of things that need to be done, right? So that Rett test can take anywhere from 2 to 4 weeks. Usually some places I've heard it takes 6 to 8 weeks, right? So you don't necessarily have to, wait for that before surgery. So if you're not going to wait for it, then you can always assess for a pheochromocytoma, which is the tumor of the adrenal glands that produces adrenaline, right? And you need to know if you have that before you go forward with surgery. So there is a blood test called plasma metanephrin or there's urine studies that can be done to look for this, but it will change the timing of when your medullary thyroid cancer will be treated, because the surgeon will want to take care of the adrenal glands first before the thyroid cancer in most cases, right? So this discussion needs to occur. So if you're not waiting for the Rett testing, then go ahead and get this tested for the pheochromocytoma. You can also have your levels of your parathyroid hormone, or PTH, and calcium levels checked, because again, that if you have those elevated, that may change your surgical approach as well. So when the surgeon's going in for the medullary thyroid cancer, they may need to do something about the parathyroids as well. So these assessments are all important when you're waiting for the workup of the surgery to have surgery. So what are the docs actually looking for? So they're going to talk to you and examine you for a mass in your neck, whether it's lymph nodes or from the thyroid. They should be asking you, even if you don't volunteer this information, what are your bowel movements like? If you have diarrhea, many times patients will be like, oh yeah, I've had diarrhea so long, I thought it was normal, right? And that's just the diarrhea comes from the medullary thyroid cancer often. A patient can present with some flushing, like some heat and some redness. And then if they have multiple endocrine neoplasia type 2B, they will have that phenotype. They'll have that look. They can have a marfanoid habitus of their body where their arms are long and lanky. They can have raised bumps on their lips or tongue like we showed you. And sometimes if you ask them, did you ever have tears as a baby? They'll say no, right? Rarely can your medullary thyroid cancer make an excess hormone called cortisol. And so you'll have a disease called Cushing's, which adds some complexity and will need some separate treatment and workup. But thankfully, that's rare. So how do we manage? Once you've been diagnosed with medullary thyroid cancer, this disease is so rare. So if you took all comers of thyroid cancer, medullary thyroid cancer makes up 1 to 4% of all of those, thyroid cancers. So ideally, because there's specific management, which you'll hear about how special the surgical management is from Dr. Grubbs, that these patients should be referred to a high volume center as much as possible, right? Where people take care of medullary thyroid cancer all day or every day. The surgery, you'll go into detail with Dr. Grubbs. You remove the whole thyroid, what's known as a total thyroidectomy, as well as a central neck dissection, right? You always do that at a minimum. And radioactive iodine is not used here. And then because the thyroid's removed, you need to give back the patient thyroid hormone, but you keep the thyroid blood test normal, right? Different from the other thyroid cancers where you give them a little more than your body needs. In medullary thyroid cancer, you just keep it normal. So what are tumor markers? Next. So basically in any cancer, right, you need a blood test to help you follow your cancer, right? So in prostate cancer, you've heard about people measuring a PSA. So in medullary thyroid cancer, thankfully, we have 2 blood markers we can follow. Okay. So these tumor markers or cancer markers are like a protein or substance that can be measured in the blood that will help us follow up the state of your cancer, right? Or in general for most people. So calcitonin is the main one. And the second one is carcinoembryonic antigen or CEA. So these are blood tests that tend to be measured before surgery to help determine if the cancer has spread outside of your neck. So we do want it before surgery. And then it's also measured after surgery and in follow-up to see if someone's cancer-free and what's happening to those levels over time. So on this, this is a page from the American Thyroid Association guidelines. I'm so sorry that it's so small, but if you look under the first box, it says thyroid nodule, and the one that's in red tells you what you should do, right? So one gets a comprehensive neck ultrasound, and you measure the calcitonin and CEA levels. CTN is calcitonin. And then you should have, it says there, DNA analysis for germline mutation, which means the genetic testing we talked about, right? So all that's done. Next. If one has, now, whether or not you have a RET, then you deal with those familial syndromes, et cetera. But I wanted to focus here on what it says there at the bottom in the red box. If your calcitonin level is less than 500, right, then your medullary thyroid cancer may be limited to the neck, and you go ahead and go forward with talking to the surgeon about timing of surgery, et cetera. But if it's more than 500, next, then look at the right-hand side of this. You do imaging to see if the medullary thyroid cancer has spread outside of your neck, namely what's called distant metastases, meaning thyroid cancer outside of the neck, could be liver, lungs, bones, and we can talk about that. But I think there's a couple of other sessions on that before surgery, because now you want to have a discussion with the surgeon and the endocrinologist about timing of surgery and what else needs to be done, if anything, right? So it's a very important step and why we measure it before. So let's go back to our original patient, right? It was a 65-year-old lady who had found her own thyroid nodule and had some diarrhea. She's now had a biopsy and has been diagnosed with medullary thyroid cancer. She doesn't have any physical features of MEN2B, but the RET testing was not back, that hereditary testing in the blood. So we went ahead and did blood testing to look for that adrenal tumor that makes extra adrenaline called pheochromocytoma. She did not have that. And we checked her PTH and calcium, her parathyroid hormone and her calcium, and she did not have any parathyroid problems. So she doesn't seem to have any problems that would get her into trouble, even if she does have familial medullary thyroid cancer. So her calcitonin was measured and it was found to be 240. So it's less than that 500 mark. And her CEA was 10. An ultrasound of the neck showed that she had a 3-centimeter nodule that was biopsied as medullary thyroid cancer, but the rest of her lymph nodes looked okay. So I'm going to now pass the baton to our lovely surgeon, Dr. Grubbs, that to ask the question, is surgery the next step and where do we go from here? Thank you, Dr. Grubbs.
Great, thanks so much. So we'll now start talking about surgery. There are a couple questions in the chat. And I'll try to work these in at some surgical questions, and we'll work them in. And if I don't answer them to your satisfaction, just shoot us a text again that says not so fast. So, you know, as a surgeon, what am I looking for? So when I'm looking in the neck, I'm really looking for at 2 main parts. I'm looking at the central neck, which is where the thyroid itself lives, as well as lymph nodes that are directly touching and adjacent to the thyroid. That's, if we want to even get a little fancier, we call that level 6 and level 7 lymph nodes. I also am looking at the lateral neck, which is the part of the neck that is to each side of that central area. And I want to see, as Naifa talked about before, that's what that comprehensive neck imaging does. It allows us to look at those areas as well, because sometimes medullary thyroid cancer can spread to those lymph nodes. And we want to know that when we're planning our first surgery, so we can do as complete a first operation as possible. So here again, as we talked about, is that central neck area. This is the thing here that's demarcated by those black lines. And you can see that the thyroid is there behind that VI, that 6 Roman numeral. And then level 6 lymph nodes are in that area, whereas level 7 lymph nodes are actually lower in the chest, a little bit behind the breastbone. And these are the areas, this is the lymph nodes within the central neck that we aim to remove when we do a surgery for medullary thyroid cancer. Now, we usually talk about taking out the entire thyroid in these cases if there hasn't been an operation before. And so therefore, we usually talk about doing a bilateral central neck dissection, meaning taking out lymph nodes on that right part of the central neck where that right lobe of the thyroid or half of the thyroid is, and the lymph nodes on the left side of the neck as well. And we'll talk a little bit about how we could deviate from that when I answer some of your questions. So when we go back to the ATA guidelines, the preferred operation when you are talking about having been diagnosed with medullary thyroid cancer and coming in and not having surgery yet, we usually, the usual answer is going to be total thyroidectomy with bilateral central neck dissection. Now, this is particularly important when we're talking about folks that have that 25% hereditary form of medullary thyroid cancer, the one that runs in the family. And the reason, how I think about that is, in this setting, we really want to take out every cell that could eventually develop into a medullary thyroid cancer, because each cell in the thyroid has that mutation that can cause that cell and push it to become a cancer. So certainly in hereditary cases, we really want to make sure we're doing a complete and total thyroidectomy. We usually talk about this being the same for sporadic, but we'll have some slides in a bit that might describe that better. Oh, a train going by. What is a neck dissection anyway? I mean, it sounds so vague, right? Like everybody usually gets this idea of taking out the thyroid. It's an organ. But what are these lymph nodes? When you look in the neck, are they just sitting there, or what is it like? So this gives you a good view. We actually created this picture for one of our guidelines a couple years ago. And what you're looking at is the front of the trachea there. Half of the thyroid, that right side of the thyroid, is actually removed in this setting. And what you're seeing is behind the thyroid, you're seeing these lymph nodes, which are kind of the bluish hue there. You're also seeing that inferior parathyroid gland and also a superior parathyroid gland, which are actually things that we want to save because they regulate our calcium. So we're trying to go in and remove all those lymph nodes, but at the same time, keep those small little organs intact that allow you to keep your calcium the way it's supposed to be. So what you're seeing there is a right-sided central neck dissection, just taking out the lymph nodes on that right side. And then the idea is you go to the other side and take out the lymph nodes on that other side as well. So why can't you just look for abnormal nodes in the central neck? Meaning, why can't I just get in there, move your thyroid out of the way, take a peek and be like, well, nothing looks weird to me. I'm good. Let's just leave the lymph nodes in place. Well, it turns out, as surgeons, we don't ever like to say that we don't know everything, but it turns out we really are not good at all at looking at lymph nodes and deciding whether they're metastatic or not. When you look at a surgeon's intraoperative assessment of the lymph nodes, our sensitivity and specificity, how good we are at identifying whether these nodes are positive for disease, is not very good. It's a little better than a flip of a coin, but not much. So in this setting, we say, let's just plan on removing those lymph nodes while we're there. Why that is so important is because you, certainly as the patient, only want me to go in your neck as few times as possible, and hopefully once. And I, as a surgeon, really don't want to be revisiting your neck unless we really have to, because each time we go back into your neck, it's a little bit more challenging of an operation to be able to save those parathyroids that I was talking to you about that regulate our calcium and that you need, to be able to preserve the nerve that runs in that area called the recurrent laryngeal nerve that innervates your vocal folds and allows you to talk the way you do and breathe the way you do. So we have one chance to do a first good operation, and that's why one of the reasons is we really don't want to wait to go back until the lymph node grows and becomes concerning. We want to go ahead and address it at the beginning. So can a preoperative calcitonin level guide your central neck dissection? Meaning, okay, if I only have a calcitonin level that's slightly elevated, could you just take out my thyroid? Because probably there's only cancer in my thyroid, and probably it hasn't gone to the lymph nodes yet. And what I would say is, looking at a study that was done a number of years ago now, and published in JCEM, which is one of our endocrine journals that we all use, is that when they looked at patients and looked at baseline calcitonin levels and looked at whether then when we took out their lymph nodes and looked at them under the microscope and figured out where the metastatic disease was, that once your calcitonin got above 20, they started to see disease within that central neck. And so we kind of use that as a guide to say, you know, your calcitonin would have to be really, really low for us to say, we should just take out your thyroid and not take out your central neck nodes. So low that I think very few of us would feel comfortable just doing that, meaning just taking out your thyroid if you have a known diagnosis of medullary thyroid cancer and not removing the lymph nodes. So what about the lateral neck? We talked a little bit about the central neck, which is that Roman numeral 6 and 7 there. But now let's talk about the area that's to the left and the right of that area, which is the lateral neck. And usually, again, this is the fancy term that we use, are these Roman numerals to tell the different levels. Is usually what we're talking about are levels 2A, 3, 4, and usually 5A that we use. Sometimes we will go and do a more extensive lymph node dissection with levels 2B and 5B, but that is less likely of where thyroid cancer tends to go. And we do that selectively based on the imaging and what we find at the time of surgery. So what is the preferred operation if you are found on your ultrasound or your CT or your physical exam to have nodal disease that is then usually followed up with a biopsy prior to surgery, and you're found to have lymph nodes in that lateral neck area? So what we usually do here is we do what we call a compartment-oriented dissection of those areas that have known disease. And what I mean by that is we go in and we take out lymph nodes with an anatomical boundary to them. We don't just say, oh, there's that lymph node that we saw on ultrasound or on CT. I'll just take that fella out and leave everybody else behind. No, because if we do that, what we have found is in 2 years, guess what? His neighbor next door has now grown medullary thyroid cancer that we can now see. And then you and I are going back to the operating room. And as we talked about, nobody wants that. So we'll go ahead and take out all of the lymph nodes in that lateral neck in this compartment-oriented disease. As we talked about, usually that's going to be, even if you only have a lymph node that we see that's positive in level 4, we'll go ahead and take out lymph nodes in at least levels 2A, 3, and 4, and usually 5A, because we know from experience and looking, doing studies on this, that if you've got them in 4, there's a good chance that they're elsewhere as well, and we want to go ahead and take care of that. So, one thing that I will say that, and my frowny face here is that the American Thyroid Association has the view that, we in the United States usually, and certainly in my practice, if you don't have any concerning lymph nodes in your lateral neck by good quality imaging, we don't go and do a lymph node dissection in that area. We say, okay, their lymph nodes, the imaging all looks good. We don't need to do that extensive an operation. Some physicians, and this does tend to be more in Europe than in the United States, say, well, if you have a calcitonin that's elevated above 20, you should go ahead, even if you don't see any nodes, you should go ahead and just plan on cleaning out those nodal basins so that you don't develop medullary thyroid cancer in the future. And we have found that in our hands, that's a little bit too extensive for us. One of the reasons why this came, and so it's 20, one of the ATA guidelines is you can either just use imaging like we do to help you make the decision of the extent of a lateral neck dissection, whether to do it all or not, or you can use calcitonin to help you. If your calcitonin is greater than 20, they would say go ahead and clean out the lymph node basin in the lateral neck on the same side as your medullary thyroid cancer. And if it's greater than 200, go ahead and clean out both lymph nodes basins, the right and the left lateral necks, which is not a trivial amount of operating. I just want to put out there. Where they got this data is, again, going back to that same paper, they looked and found when was the first time that the lowest the calcitonin was where there was lateral neck disease. And for lateral neck disease on the same side of the cancer, it was 20. So that's why they came up with 20. And then for neck disease, nodal disease on the opposite lateral neck, from where the cancer was found in the thyroid, they would say if it's over 200, do that. What we say to that is, okay, understood. If that is how you want to approach things, that is absolutely reasonable, and that's what the ATA guidelines said. But our thought in this is this was really done in an era before ultrasound was routinely done. Good ultrasound was done, and so we think this is a little bit of a potentially skewed way of looking at the data, and really it's time for a new set of data to be looked at with this study revisited in the new ultrasound era, which we're working on now. So what are the risks of surgery? And these are things you really, really want to feel very comfortable that your physician has talked to you about, your surgeon has talked to you about these things, and if they haven't, you say, hold on, I'd like to go back and talk again about the risks of the surgery. In the central neck, we talked a little bit about this, but the biggest things that we care about is potential compromise or injury of that recurrent laryngeal nerve, which is that nerve, that yellow spaghetti piece that runs on each side of the trachea there. That's the thing that innervates your vocal folds and allows you to talk the way you do and breathe the way you do, because it allows the vocal folds to move in and out. You want to be really thoughtful. When we do this operating, we're finding those nerves and preserving them. But there is risk every time we do these operations of compromising those nerves. The biggest risk when you talk about the recurrent laryngeal nerve is the potential of having hoarseness, because you usually, if you're going to have an issue, it's going to be on one side of the neck, and it's going to cause that vocal fold on that side not to go in and out. And so you can have a hoarseness that is, if you're going to have it, it often is temporary, but 1% of the time, or 1 out of 100, it can be more permanent. In a very, very rare setting, if you have both nerves that don't work after surgery, you could have an airway obstruction because both of the vocal folds that the nerves innervate don't move, and you're blocking the airway. And in that exceedingly rare setting, you would have, and 1 in 10,000, exceedingly rare, you could need to have a trach or a tube that's inserted in the trachea to allow you to breathe, which is something obviously is such a challenging quality of life issue, something we think about quite, one of the major things that we think about every time we do this operation. The other thing we talk about is injury to those parathyroid glands, which are the little glands that we want to actually leave in place that regulate your calcium. We have 4 of them. They're so important. These glands are so important that we get 4 of them. I ask you to think about how many organs we have in the body that we get 4 of. Not that many. That's how important it is. Now, the good news is you only need 1 of those 4 glands to have normal calcium afterwards, but we do everything in our power to save as many of them as we can. So that is the idea of when we go in the neck, we're trying to take out certain things, we're trying to leave other things alone, and it takes experience and expertise to do this well. In the lateral neck, you've got other important nerves that we watch, things including the vagus nerve that actually goes around and innervates your recurrent laryngeal nerve, so still part of that very important nerve with your voice. Spinal accessory nerve that allows you to shoulder shrug well, your phrenic nerve that allows the diaphragm, which is that muscle between your chest and your belly, to go up and down, and then your facial nerve that allows you to have the fantastic smile you have. And then a chyle leak is something that when you have when you take out lymph nodes, sometimes you'll have fluid that is lymphatic fluid that leaks from those areas that can cause swelling in your neck. And that's a lot of times why with lateral necks, folks will put drains in. And then if you take out the whole thyroid, for sure the risk of surgery is 100% you're going to need thyroid hormone replacement if we remove the whole thyroid. So one thing I do want to say before we go on to the next part, I just want to answer a question that was asked about, if I know that I don't have the hereditary form of the disease, is it possible that if I have a small medullary thyroid cancer and my calcitonin is not that elevated, because remember, calcitonin, the higher the calcitonin, we think the more advanced disease we have, the more disease that we have with, within the neck or throughout the body. But if I have a small medullary thyroid cancer and my calcitonin is relatively low, is there any thought behind doing a lobectomy or just taking out half of the thyroid? And that's a great question. And I think that if you are at a place that really understands medullary thyroid cancer and you're a doctor and you want to have this very informed discussion, it is something to consider. I will say that, where I have seen this in discussions I've had and we've had in our multidisciplinary conferences at Anderson would be someone that really is interested in retaining part of their thyroid to have some of their own thyroid function. And what you would be talking about in this setting would be doing a thyroid lobectomy or taking out half the thyroid and then really taking out the lymph nodes in that central neck just on that side, and then leaving the other side untouched, so that if you had to go back and do another operation, it really would be like the first operation on the other central side of your neck. But that's a really specialized conversation you're going to have. You're going to juggle how high is the calcitonin, if it's pretty low, under 20 as we just talked about or less, you could have that conversation. So to answer your question is, if you're working with physicians who really understand this disease, then you can have that conversation with them. And that is not out of the realm of something to discuss, doing a lobectomy for a sporadic. It's not the norm, but it's something that could be discussed. Okay, I'm turning it back over.
So thank you so much, Dr. Grubbs. Before we go on to the follow-up, we answered all the questions in the chat. There are a lot of great questions coming up. Some are using the chat, some are using the Q&A, but I do want Dr. Grubbs to address 3 questions. And so one of them says, how long after surgery can you identify if the laryngeal nerve was permanently damaged? I am post-op 14 weeks and have continued issues with hoarseness, swallowing, and trapezius muscle issues. So I think that would be a great question timing-wise for you.
Fantastic. So, okay, so let's talk about this. So again, when I talk to patients about counseling, with the nerve, what are the risks? Again, about 95% of the time, you're not really going to have any compromise in the nerve. After surgery, you can have hoarseness, but it's usually that breathing tube. About 4% of the time, you can get that temporary hoarseness. And how I always say it, and if I have patients that are listening to me that are my patients, they know what I'm going to say. It's like your nerve is bruised. And when your nerve is bruised, it can't function the way it's supposed to. So it can't fire and have that vocal fold go in and out. That bruising can last a fair amount of time. And so when it happens with our patients, usually if they're doing well otherwise in terms of not having problems with choking or aspiration when they swallow, we'll say, let's look at that nerve again at about 3 months. Okay, so that can give you an idea. But honestly, up to about a year, you can see continued improvement in that nerve. So you're still within the realm of there being ability for it to recover. Now, I will say this, guys, I'm saying this as if you're going in and taking out, disease that is not involving the nerve. sometimes medullary thyroid cancer can involve the nerve, the tumor itself can invade the nerve, and sometimes we have to take that nerve on purpose. And when we do that, we'll oftentimes reconstruct it. That's a different thing, and your physician will talk to you about this if that's something they have to end up doing. A lot of times we'll have an understanding of whether we think that's going to be a risk prior to surgery from the imaging that we do. We can tell if the tumor is going to be near to the path of the nerve, but that's the only time I'll give you the caveat that if your surgeon after surgery said, listen, the only way to take all the disease out was to resect that portion of the nerve, then we're talking about something different. But the swallowing as well, you can have kind of persistent swallowing issues for a while. The things that require more immediate follow-up with your physician would be if you're really choking a lot or what we call aspirating, when food and drink goes down the wrong pipe, goes down into the trachea instead of the esophagus, that would be a time to talk to your physician, again, if you're having that. Because, that idea is, are we not able to protect our airway well? Is that vocal fold that can't go in and out, is it stuck in a position where it's not doing its normal job of protecting the windpipe or that trachea when we eat and drink? And if that's the case, then we might need to do something to help you with taking that cord and moving it to the midline so that it naturally can protect your airway. Again, really important discussions to have with your physician, really important discussions to have with your surgeon. And a reason you really want your surgeon to do a lot of thyroid, they're going to be doing this so that they're very aware of these types of things. Okay, and what else?
Point. Yeah, so excellent point. So related, one related question, one unrelated question. So can you remove surgical clips that were placed in a patient without their knowledge or consent during a lobectomy? They're causing a lot of constant pain, poking sensations, and need to come out.
Okay, so could you remove the clips? So I will tell you that we don't tend to use clips where I don't and my colleagues don't because recurrences can happen in medullary thyroid cancer. We know that. And when we're doing imaging, for re-imaging for medullary thyroid cancer, when clips are in the way, they sometimes can inhibit us from really getting a good look at the imaging because they kind of block the view. They can cause this distortion. So if I go back and I'm operating on someone who's had clips in the past, I work very hard to take out those clips when I can, so that it won't bother us in the future. Now, would you have a second surgery, not because there's disease there, but just to remove clips? That's a really challenging one because going back and doing additional surgery, we talked about is risky because the more times we go in, the more likely we are to potentially hurt that nerve or devascularize or a fancy word for saying take away the blood supply for the parathyroid. So going back in just to remove clips is something we'd really have to think hard about. That's a heavy sigh if you didn't hear it. Can I tell you that your clips are absolutely causing you pain? They usually don't. Now, that being said, the only way to know for sure, I know, is if you removed them, right? But I will say most of the times the clips themselves are often not causing discomfort. I know that's a challenge though, and each case is very individual. So I'm not going to make any sweeping generalizations about that.
There's a question about a 37-year-old patient who has RET positive, calcitonin and CEA are low normal. Should she have a central lymph node dissection or just a thyroidectomy? And interesting question about, is it okay to wait for after IVF pregnancy?
Then okay, I'll start answering.
Okay.
Okay,
so,
I will start answering those in the chat, and you and then just tell me when. I'll multitask, and then I'll forward the slides when you tell me.
Okay, so I've been putting an @ sign and the person's name so they know to look for the answer, but it goes to everyone, so they can learn.
You got it.
Okay. All right, guys. So now we'll talk about, the patient has been diagnosed with medullary thyroid cancer, and what do we do? How do we follow patients up? What are the imaging and the tumor markers that we look at? So we talked about that calcitonin and CEA are proteins in the blood, that tumor markers that are very sensitive for disease that we can measure. We measured them before surgery, and then we measure them again after surgery to see if a patient is cancer-free, okay? The nadir, or where it goes to its lowest point that it's going to, can occur as late as 6 months after surgery, okay? So different from other types of thyroid cancer. But if it is measurable after surgery, oftentimes what you'll do is you'll follow it over time to evaluate what's called the doubling time, right? Or how long does it take for that number to double? Because that tends to inform the patient and the doctor about what is the overall prognosis, meaning how is a patient going to do? If it doubles very quickly, like every 6 months, then that tends to be more fast growing disease. Whereas if it takes 2 years to double, that tends to be more slow growing disease, right? Now, you know, when the numbers are very small, like 2 going to 4, that's very different than if I'm 400 going to 800. Okay. So, you know, there is a slope to that line. Rarely, and somebody asked this great question, which we answered in the chat, what happens if medullary thyroid cancer does not make calcitonin or CEA? And those are harder to follow, but we tend to rely on imaging. So what about advanced and recurrent disease? Next, meaning disease that's either beyond that has come back to the neck when there was no disease there, or we still have calcitonin that never went to 0. Next. So this is an algorithm page from the American Thyroid Association latest guidelines. And again, I'm really sorry that it's small, but on the left-hand side, it starts with, if I've had surgery, that's what TTX is, total thyroidectomy. And now after surgery, I can measure the calcitonin, but it's less than 150. Okay. And there's no evidence of disease on physical exam or on the ultrasound of the neck, because remember, medullary thyroid cancer loves the neck. Then what should be done at that time is ultrasound of the neck every 6 months and a physical examination to see if there's anything there. And then one should measure the serum calcitonin and CEA every 3 to 6 months to determine what that doubling time is, okay? And for doubling time, there's actually a calculator on the American Thyroid Association website. If you need it, you need 4 points over time to look at what that doubling time is, okay? So if the calcitonin is greater than 150, then you need to do imaging procedures to see, right? To look, where is this medullary thyroid cancer? So if you have that calcitonin, right, that it was less than 150, then you went to neck imaging and calcitonin CEA every 3 to 6 months. And if it's greater than 150, then you want to do imaging procedures to look for the cancer outside of the neck. Next, and where does it tend to like to go? Well, it likes to go to liver. When we tend to do a special CT scan or a special MRI, informing the radiologist that we are trying to look at the liver, because the liver can be one of those tricky things where you have to look at the blood flow coming in and out. So one option is called a 3-phase CT scan, or there can be a liver MRI, depending on what's better done at the hospital that you're having or what the radiologist used to looking at. The other place that it likes to go is what's called is the spine. We call that axial MRIs, where we order to look at the spine because it can hide in the bones of those spinal bones. So the calcitonin number before surgery helps you determine whether you need to look for things outside the neck. And then there's also a separate calcitonin level that's helpful after. Okay. So in summary, which is good, we have a few minutes that we can answer some live questions that we can't answer in the chat. So in summary, medullary thyroid cancer is a rare neuroendocrine tumor of the thyroid. And everybody should have blood tests for hereditary medullary thyroid cancer called RET germline. So, and then if your RET germline testing is not back before you're going for neck surgery, please make sure that your surgeon or endocrinologist has checked for the adrenaline-producing tumors of the called pheochromocytoma and or parathyroid and calcium glands. Next. Multidisciplinary team is key. That means several people from different specialties talking about you. And it's, you are your best advocate, right? So you can, I would go with written questions to the doctors because we tend to get nervous. Doctors tend to be in a rush and, go with your questions, ask them, key questions and ask the same questions of your surgeon endocrinologist. So multidisciplinary team is key. Ideally, if a patient with medullary thyroid cancer can at least go for a consultation to a high volume center, that would be ideal, but especially for surgery. And just to remind everybody, finding that awesome surgeon who knows medullary thyroid cancer and knows when to operate, when not to operate, and when to be extra cautious, because surgery is the only chance at cure. I know that I'm an endocrinologist and, you know, I love to, you know, if I see a nail, I want to hammer it, but the surgeons are your key to your cure. So Dr. Grubbs, our hats off to you. Next. So I think what we were going to do here is go for some questions. So I don't know how far Dr. Grubbs has gone in the Q&A, but we can ask them live if it's appropriate, or I can type.
Not very far. I wasn't doing a good job of multitasking. So let's see. Let's go back up to...
The Q&A is done. They were saying thank you about your clips. You answered that. Did you answer about the 37-year-old with a RET positive, low calcitonin and CEA? Do you need a central neck dissection, and your discussion about IVF? Do you want to talk about IVF and pregnancy live, or did you answer that already?
No, I did not answer that one. Okay. So let's have this discussion, because this is like, so I'm going to go with RET positive. So we're going to talk about the 37-year-old daughter, also RET positive with a calcitonin and CEA below normal. So a couple of thoughts on this. Should she go forward with surgery now? Can she wait until she undergoes IVF pregnancy? So what I would say here is, with the RET, so she has a germline mutation. And when we have adults that have germline mutations that are found by screening, meaning that she had her germline screening because you had or someone in the family had medullary thyroid cancer, she got tested and was also found to have that germline mutation. The mutation, and so a couple things help us understand where we are with her in her disease course. She very well may, if she has a mutation that, a certain RET mutation that tends to be a little bit more indolent, meaning that she will develop medullary thyroid cancer, but potentially later in life rather than earlier. And she has a, undetectable or normal calcitonin and CEA, she very well could, we could say, let's just continue to watch her. And really, we're looking for when that calcitonin starts to elevate. We have a number of patients that we are doing that with right now, that as long as they have normal calcitonins, we have the discussion about continuing to watch. Now, we've done some nice work on looking at which mutation, kind of predicting which mutations you can even be more comfortable doing that with. So that's going to be kind of a nuanced discussion with her. What I will say is, one of the questions is, when she does, should she have a central neck dissection or just thyroidectomy? When she goes to have surgery, we're going to do the discussion of if we don't think she has any evidence of disease, this is just being done prophylactically or taking out her thyroid prior to surgery, prior to cancer developing, we can have the discussion of just doing a thyroidectomy and not a lymph node dissection. That, again, is something, though, that you're going to want to think through very carefully during the surgery. Like, if she has any concern of lymph nodes, to think about doing a neck dissection with it, because, when I go in to do I just did a prophylactic thyroidectomy on a patient this week. Calcitonin was around 25. So I don't know if he just has that pre-malignancy and not really cancer yet, or he has cancer. And if he has cancer, I'm going to probably want to do a lymph node dissection. So you've just got to be, it's a little bit of a gray zone, and you just have to use your expertise to know what extent of operating to do. That was confusing, I'm realizing, as I'm saying all this. So if you want to stay on after and have more questions, I'm happy to have it.
Okay, so we have 5 minutes left, and I'll tell you a couple of things there's a couple of common themes that we can go through here. I think a lot of these questions were answered either in the talk or in the chat, so that's great. So there is an interesting question that I think would be good for Dr. Grubbs about neoadjuvant, which I will ask you in 1 second. I wanted to address, somebody had mentioned that the calcitonin and how to calculate calcitonin and CEA doubling time, the ATA calculator has been down for some time. You're right. I didn't realize the ATA website is down. The apps that are available are down. So if you just take, to answer both questions at once, so you measure the calcitonin and CEA, the naters at 6 months. Some people like to get it at 3 months, depending on how fast the disease is growing. Know that 6 months is when it naters, and then it tends to be every 3 to 6 months, depending on your disease. But very often, if you have fairly stable, low volume disease, it's every 6 months. So the doubling time calculator, you need 4 measurements, and you look that if it's doubled over time. And then the question, let me come to the neoadjuvant in the interest of time, because we have like 3 minutes, and I think it's going to take Dr. Grubbs a little while to answer it. So the exact question was, you know, if medullary thyroid cancer is so advanced and it has a RET mutation, I think they're talking about, this is in another advanced talk about measuring mutations or changes on the cancer itself. If it's treatable with a chemotherapy called a tyrosine kinase inhibitor, is it common not to do a total thyroidectomy if there's no disease in the alternate lobe? I'm sorry, I thought they were asking if you can treat with chemo and then surgery. I'm not sure. I wish Brian could unmute and ask. I apologize.
Well, I will say this, and maybe this will help, is you're right. Once the disease is outside of the neck, how surgeons are involved is we understand that surgery isn't the cure in that case, right? The thyroid, you know, cancer primary might still be in the thyroid, but if the disease is then spread, say, to the liver or the bone, all the work I'm going to do in the neck isn't going to cure from disease. And so then the surgeon has to work with their colleagues to say, A, do we need to do any surgery, or do we need to be focusing on treating the disease that is spread elsewhere? Or do I need to do some surgery because the disease elsewhere is very small and probably is going to take years to decades to grow, so let's go ahead and do a complete operation in the neck? Or do I need to do some modification where I just treat the disease in the neck, if it grows, they're going to get into trouble locally. It's going to maybe grow into the trachea or the esophagus, or really start to, you know, have the patient have symptomatic problems. So in that setting, we really have to work in the multidisciplinary setting to figure out what is the end goal for the individual patient and how does surgery best fit into that. Whether it's no surgery, some surgery, or doing a, you know, resecting all disease within the neck.
Okay, fantastic. In the remaining minute or so, there is a question. Thank you, Peter, for the question. If the disease continues to recur in the lymph nodes in the upper mediastinum, what are all of the treatment options, and can multiple surgeries occur in this region? And another question was, does the vagus nerve ever get involved? That's probably not related, but I'm throwing the questions in the last minute.
Sure, you got it. So yes, all nerves can be involved with, you know, wherever the medullary is. Again, we do everything in our power to try to preserve these nerves while saving, while removing the disease. In terms of the mediastinum, a really good question. If that is the only site of disease and we feel like it's resectable, sometimes we will do what we call sternotomies, or opening up the breastbone. A lot of times what you'll see with open heart surgery, when you open up that breastbone, to be able to get to the disease, to remove it. Sometimes, though, that is too morbid, meaning, and we're not going to get all the disease out. And that's when we kind of shift our discussion back to Dr. Busaidy and say, would this patient benefit, you know, if the disease is significant enough, would this patient benefit from more targeted therapy that she provides? And so that would be the discussion there. Going back into this area multiple times, it's challenging, just as it is because, you know, that nerve, that recurrent laryngeal nerve that we're talking about, goes down into the chest. So we're not free from it when we leave the neck and go down into the chest. So the same idea behind multiple surgeries, you know, there's increased risk there, but again, we balance this.
Thank you so much for coming and spending time with us. This was amazing. And I wish we could do this in person. It would have been fun to be in LA together. But next year, hopefully we'll be in person, hugging and chatting and taking our time. So thank you so much. Good luck in your next sessions. There's 4 other sessions on medullary thyroid cancer about answering some of your questions. So please attend those. Thank you, guys.